Alright guys, this is the last video in the pediatric part. I know it's been kind of long and I apologize for this, but I will tell you that it beats 371 slides in class. Alright, let's go back to the trauma emergencies. And again, remember, trauma is probably the #1 killer of our patients under the age of 13. So remember, the younger they are, again, they're a little bit more resilient, but they're very susceptible to trauma. And again, the biggest ones again is your falls and your motor vehicle collisions. Okay, and again, improperly seated kids. Oh, put them in a seat belt. Make sure they're in a car seat. They're in the proper car seat. That they're facing the right way. This is why we put the kids in the back seat where the airbags doesn't deploy and hit them like so. Okay. Again, vehicle versus kids. Remember, think about where they got hit. The kinematics of it. And remember that kids usually turn towards the car because they don't know the danger of the car. So they usually turn towards it instead away from it, okay? Again, submersion injuries, unfortunately drownings. We live in Florida where everybody's got a pool in the backyard. And they don't all have fences around it. And they didn't watch the kid. And next thing you know, they're in there near drowning events, okay? The older term was the near drowning. It's no longer used technically. But now there's drowning, or again, drowning is considered it is a fatal or non-fatal drowning. All right. So again, 20 to 25%, they do have neurological defects. So again, your effort should be on the ventilations here. Okay. I will tell you, in Florida, the water doesn't get cold enough for this cold water to be into effect. Okay. The idea is it cooled the body down. This is usually a rapid submersion. It gets the mammalian diving reflex involved, where the cords spasm and the lungs are dry at that point. So the best treatment, by the way, is prevention. Make sure that they don't actually get into the pool to start with. Unfortunately, we do have a lot of firearm injuries. Usually we hear about one a year around here they find the gun and they decide to play cops and robbers, except there's 3 bullets in it. So again, burn injuries, by the way, leading cause of accidental death in the home for kids under the age of 14. This also involves structure fires and fire and smoke related injuries. And again, just physical abuse, guys. Child abuse, unfortunately, very rampant. A lot more rampant than we want to really admit. Okay, and especially right now during COVID, when this is the time of this being made. Remember that these kids are being cramped up. They're having to deal with confinement, and sometimes emotions go over the line. Airway control, again, just remember, maintain their airway, and I'm going to tell you again, OPA is your friend here, okay? G-tube placement if we need to decompress the stomach, just kind of remember that. If you need to hold the C-spine, this is a good method in which to do so for your pediatric patient. Again, anything that stabilizes the neck, don't be afraid to be creative on your pediatric patient. The whole goal is keep the neck from moving, not necessarily make the collar fit the patient, okay? So be imaginative when you're doing that, okay? Fluid management, again, remember, these guys usually need blood products, not hypovolemic restoration, okay? So they need blood products. So don't go get a large bore line in them. But just remember, after about that 3rd fluid challenge, we're probably turning the blood into Kool-Aid. And again, Kool-Aid doesn't move as much oxygen around as a blood product does. Okay, 20 cc's per kilogram again is your fluid resuscitation for most of your pediatric patients. Pediatric patients should receive analgesics, by the way. Unless contraindicated, fentanyl is your friend, okay? Consult med direction for this, but it's usually 1 mic per kilo is kind of the industry. I tend to be a little conservative, but understand that the kids, they can go 2, 3, 4 mics and be okay. So, but give it in small doses and titrate it to the effect that you're gunning for, okay? Traumatic brain injuries, again, this will relate to Glasgow Coma score. Increase in the intracranial pressure. This is when we're going to see that Cushing's triad come into play. Blood pressure shoots up, heart rate goes down, the breathing gets erratic or slow, deep respirations. You'll get bulging fontanelles in the infants. So again, and that's the signs of herniation, by the way, is you're going to start seeing posturing, okay? And if you're seeing posturing, probably that's not going to be very good. Glasgow less than 8, consider intubation for them. And RSI is, again, when you still have muscle tone that's preventing. Again, guys, I would try my BLS airway as long as I'm ventilating good. Maybe hold up on that one. Again, traumatic. If you're intubating a pediatric patient in a trauma situation, it's usually not a good prognosis. It's probably going to be a very difficult intubation, especially the younger the child is. We talked about all these special. Let's see, chest injuries. Again, double check for your pneumothoraxes on these guys. Again, also your cardiac tamponade. Remember that the chest. The rib cage is very pliable in these guys. The other thing you can get is also a lung tissue herniation. I had a kid had a weight dropped on his chest, and so it was sticking out like a little alien and kept popping out. The way they put it back at Shands was they literally just kind of spread the ribs and pushed it back in. Never had to open up the skin. It was actually, I was like, ooh, wow, when you were first seeing it. And of course, everybody was freaking out when I first got there. Because they were, there's a little alien coming out, Every time the little kid breathed, he was screaming in pain. Splenic or hepatic injuries, they can cause internal hemorrhage. Palpate one quadrant at a time. Again, check for the warmth as well as changes in the color of the abdomen as well. We need to be able to see these guys, okay? Usually the bones in these guys, they don't break. They bend, they green stick. They're not, the bones aren't as hard and calcified, okay? Now, once they get up around age 4 or 5, that's when the calcification occurs. They start breaking bones, okay? Again, rule of nines, remember that they are a little bit different for your pediatric patient, okay? Remember when I said the front and back of the head, this is now 18. And we take that, by the way, from the back of the legs. The legs are where we take that from. So again, you need to know the rule of nines. Study the rule of nines. You're going to need it, I assure you. Matter of fact, National Registry loves rule of nines, okay? So make sure you know your rule of nines for both the adult and the pediatric patient, okay? Thermal burns, again, we want to make sure that we take the airway, especially if we think we got respiratory involvement, okay? Think 1 to 2 sizes smaller because of the swelling, okay? That swelling is not going to get better, by the way. The longer you wait, the worse it's going to get, okay? Maintain your body heat, and if it's a serious electrical burn, remember to perform spinal immobilization because it can tetany all of the muscles along the back of the bigger muscles, and it can actually break bones due to this. SIDS, we've gone over that in EMT school. This is where we can't really explain. Matter of fact, the more appropriate term now is sudden unexplained infant death. Again, usually it's not be hereditary. It's usually because of factors they just don't know. The thing is, though, is that there's a lot of times where people put their child in a suffocating position. They sleep on top of the child accidentally because they would let the child stay in the bed with them. All of these things can lead to a sudden unexplained infant death, but a lot of them are explainable, okay? When we're talking about SIDS, we're actually talking about where the kid dies. They're in the crib. They were in the right position. They just literally, their immature respiratory center forgot to breathe is the current leading theory on why it is that this happens. And again, unless the infant is obviously dead, you should do aggressive care on this. Again, if the child has been down for an extended period of time, they're stiff, they're rigor, don't give these parents false hope, okay? Unfortunately, allow the family to see the dead child, expect a normal grief reaction. And so, again, the biggest probably is these are the ones that come back and haunt you 10, 20, 30 years later. Don't keep this stuff inside, and you really do need to talk to somebody, okay? You really need to talk to somebody. I don't care how macho you're. I put a lot of macho firefighters in the ground and walked in front of their caskets because they wouldn't come out and talk about these things. Apparent life-threatening events are the ALTE. This is the one where they basically wake them up before that happens, or again, these are the cases that we worry about. Again, these are the ones that get close to death, but they don't actually die. There's something to stop that. And so again, we can actually we can do but any type of ALTE, we probably do need to transport this to be evaluated by the physician. Child abuse and neglect. Yeah, there is a special place in hell for these people. And in putting it very bluntly, again, usually less than 5 years of age are the higher risk, because these guys, they can try your souls, okay? They really can. It takes a lot of patience to raise a child, okay? They children that seem special or different require more care, and okay, so it can be either intentional abuse or unintentional neglect, okay? But both of those are considered child abuse cases, okay? Physically and mentally handicapped, they have a higher risk of being abused, okay? Boys are usually abused more than girls are. The children who is not what parents wanted are definitely at a higher risk, okay? So usually it's the parent, the legal guardian, or the foster parent that does this. The caregivers, okay? Usually the abuser knows who is doing it, okay? And they are so scared that they're not going to. And by the way, this doesn't matter. Race, creed, nationality, makes no difference. Rich kids, poor kids, they all have a certain degree of risk from this, okay? Again, and usually the abuser is the full-time caregiver, okay? And that's a very unfortunate, but again, and we're not only talking about physical abuse, but also the sexual abuse or actual neglect of the child, okay? Again, there's all kinds, there's physical and psychological, and then abused children usually become abusers themselves, unfortunately. So this is an example of where they were beating with an electrical wire, and then they burned the buttocks in hot water in order to get them to stop crying. Yeah, like I said, special place in hell. Okay. Again, this is an example of putting the kid into hot water, boiling water as punishment. Okay. Again, sexual abuse is any sexual acts all the way up to sexual torture. Yes, we have people that actually do that. Okay. The victim can be male or female, and again, they usually know who this person is, and they even actually trust this person. Okay. So anytime that you've got a fracture under the age of 2, I would be expecting abuse, okay? We need to make sure to hear the story. And if the story sounds fishy, that's when we let law enforcement continue the discussion, okay? Truth be known, law enforcement should probably be there for these to do an investigation. If it's truly an accident, I've found that the parents are very upfront, very forward. They know exactly what happened, when it happened, how it happened. The problem with it is when it's an abuse case, you get 3 or 4 different stories. They're very vague in their answers, and then they try to be overly aggressive to you. So again, law enforcement, it's not our job to interrogate the parent. It's law enforcement's job to find out about the abuse. It's our job to treat the patient and keep your questioning to that. Okay? Check the areas that are covered with clothing, because it's going to be surprising the things that you find, okay? And this kid was both physically and mentally, and again, this is going to be lasting for a while. Look how the burns happened on this patient. Again, this is a lot of abuse that happened to this child. Get your medical history. You can raise an index, especially when they're being vague. Boy, they'll be vague about how it happened or change the story, or delay in seeking help, trying to get their story right. And it's kind of really, it's kind of a bad thing when you get that. Look for the multiple insect bites, the malnutrition, long-standing skin infections, scabies, the flea bites, bed bug bites. All of these things can come into play. Again, if there's lack of cleanliness, the social skills are far lower than what you would expect for that child, and the lack of appropriate medical care, that's all signs of abuse and neglect, okay? Again, manage the injuries. You don't cross-examine the parents. That's what law enforcement's for. And believe me, they're really good at it, okay? Let them do it, all right? Never leave a transport to the alleged abuser. Never, ever, never, 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 ever, ever, never, never, ever. If you think that it's abuse, guys, you get law enforcement involved. This child does not need to be left with that abuser, okay? And believe me, you don't want that to happen. Make sure that you appropriately report it. 1-800-96-ABUSE is the number in the state of Florida. These guys, they very much go to these places, especially if it's an acute incident. They show up, okay? So by all means, get them involved, okay? Special needs babies, okay? So again, these are the ones that have chronic disorders, chronic diseases that are altered functions from birth. Some of them have tracheostomy tubes. These are great things to listen to the parent. If I can impose one thing upon you guys, is guys, if you've got a kid with this, the primary caregivers have been trained in order to handle this. Listen to them. Let them help you. Matter of fact, when they're calling you, it's usually something super serious bad, but they just need an extra pair of hands or help. They know what needs to be done. They just might not have the ability in which to do so. Okay? Biggest thing with a tracheostomy tube is you get either a dislodged tube or you get a obstruction in it, usually a mucus plug, and they can't change out the tube. Again, usually suction, they usually have the suctioning abilities there to take care of it. They may just need your assistance with doing that. And by the way, if it gets infected, air leaking, those are other problems they can call us for. Make sure that when you do transport these patients, usually they have their own ventilator there, or take it with you. It's okay to do that. They usually are battery powered. If they're not battery powered, you should be able to use it in your truck. Okay? But my point is you shouldn't be bagging these kids. And when you transport them, take them to where they get their care, not the closest place. Okay? Unless that's an airway problem that is so bad that it requires immediate intervention. Guys, if it's just they need a ride to Shands, take them to Shands. Don't stop at Advent. Don't stop somewhere else unless it's the airway issue that you cannot manage, okay? And don't use that excuse. You can probably manage it, okay? Apnea monitors, this is kind of they put it on the baby's chest. It monitors for the breathing of the child. It usually helps prevent the SIDS cases. Home artificial ventilators, by the way, again, the demand ventilators. So again, usually if you get a mechanical failure, remember there's usually an emergency number on this thing. Call the emergency number, okay? Call the emergency number. If their equipment has failed and they're not ventilating, break out the bag valve mouse, start ventilating them, okay? Central venous catheters, usually they get cracked or they get pulled. Again, treat it just like a normal wound. If it's cracked, again, make sure that it's clamped off. Make sure that we're not getting a piece going into them. We don't pull the actual central line, but again, make sure that, what we don't want to have happen is this air embolism form inside. Remember, the central line goes straight into the heart, can develop that air embolus and cause major problems, okay? If there is a large lot of air in the line, try to withdraw with a syringe. If this fails, clamp the line and transport. And if it's cracked, place the clamp between the crack and the patient. And again, if they got an altered mental status, follow the crack line. Make sure that you put their left side with their head down. You're going to see that, I think, later in a question somewhere. And then again, transport as quickly as possible. The G-tubes, make sure they're in the right spot. Again, usually we just clamp these guys if there's a problem or we plug them. But again, this is the standard feeding tube for these guys. And usually you get a little bit of bleeding at the site or the tube dislodges. Diabetics, usually they get missed feedings. And so because of that, they will develop hypoglycemia because of it. The idea, by the way, is to make sure that we support the ABCs and just reduce the risk of aspiration. Okay, make sure that the patient's laying on the right side for these guys with their head elevated. So a gastric tube problem, right side. Back here is the tracheostomy management. Again, these guys right here was on the left side. We make sure that the cracked lines, if there's air in the line, again that we put them on their left side. Okay. They can have shunts, by the way, and usually the shunts they're talking about is from the brain to the abdomen. And usually these guys get infected and they develop Cushing's triad because of it. Because, again, they get the bulging fontanelle, they get the swelling of the brain because that shunt is what's actually relieving the cerebral spinal fluid and putting it back in the abdomen, okay? Very common thing for them to have happen, actually. Again, nothing that we're going to do. We're going to simply transport them to the appropriate facility, support the ABCs, okay? Disability, we don't use that term anymore. Special needs is fine when we're talking about terminology with them. And again, involve the parent, involve the parent, involve the parent. I can't stress that one enough, involve the parent. Last but not least is Jumpstart. So the difference between standard triage and pediatric triage is actually a pretty simple one. For a child that is not breathing, again, an adult that's not breathing on an MCI, they're dead. We open the airway. If they don't breathe, they're dead. Black tag them, keep going. For Jumpstart, we're going to open their airway. We're going to give them 5 breaths. If they're breathing on their own, they're red. If they're not breathing anymore, at that point, we're going to black tag them. That's one of the biggest differences between the Jumpstart and the Start triage, okay? Again, there's a little bit about the 32 can do. The respirations, remember, are at 45 instead of for 30 for a pediatric patient, or below 15, then it would be that. So again, use the Start. If the patient appears to be a younger adult or older, again, we're going to use they look like a kid, use Jumpstart. If they look like a bigger kid or an adult, use the Start system. Okay, and again, Jumpstart uses the same things. Again, you're going to assess the breathing. Again, if they're not, usually the kids are too young to walk, by the way, so don't use that as a criteria as far as making them green. Okay. To sum all this up, kids can be scary. They shouldn't be. Do your pediatric assessment triangle. Okay. Get that appearance, work of breathing, and circulation. Your primary assessment, A, B, C, D, E, right? Airway, breathing, circulation, their disability status, expose them as appropriate. Okay. Your secondary exam, sample, head to toe. Tertiary exams. Okay, that would be your blood glucoses, your X-rays, all of those type of equipment. Where we watch the video on that, so we know about our assessment. By the time we get through A, B, C, D, E, we should probably know whether this is a respiratory, a shock case, or a combination of both. Okay, by the time we get done with our secondary exam, we should know whether it's respiratory distress or respiratory failure. We should know whether it's compensated or decompensated shock. We should know that, and we should probably have what type of case it's going to be. You guys are usually really good about picking out whether it's an upper airway obstruction, lower airway obstruction, lung tissue disease, or disordered control of breathing for respiratory. You guys are usually well aware if it's a shock case, whether it's hypovolemic, cardiogenic, obstructive, distributive septic. You guys are really good at that, okay? If it's a cardiac case, in other words, it's a VFib, VTAC, asystole, bradycardia, tachycardia. You guys are really good at picking that up quick, okay? But don't forget to check everything, especially go through the process. Pediatric assessment triangle, primary exam, secondary exam, okay? Go through those steps, okay? You're not, that way you don't miss something that's very important about that patient, okay? Very systematic approach when you do it, all right? With that's the end of the pediatrics, guys. And remember, they're not small adults, so remember that, all right? Remember that. They're not small adults, okay? And then treat them appropriately. There's a lot to know about them, and it's okay, because the more you know, the calmer you're going to be, and the better treatment that you're going to provide. All right, we'll see you guys on the next one.